Everybody in here has been invited specifically because of your proximity to the problem and your current work on the solution, right? So we hope there'll be some good moments. We're going to keep this like casual and very informal. I am not a very formal person, even though I got a tie on. I'm not very formal, but we just want to keep it loose and be able to provide like our voices, y'all's voices, to the topics. All right? All right, ready. So I'll get started. That's what we're doing here today. Voices of Appalachia, our Western North Carolina Behavioral Health Listening Session, which is modeled after the governor's rural listening tour. My name is Kelly Bowling. I am the Recovery Ecosystems Coordinator with Operation Gateway, and I'm primarily focused on doing two things this year: teaching and building recovery ecosystems. So if we could all introduce ourselves, I'll start it with.
Absolutely. Hello, everybody. My name is Jamia Flowers. I am here in Appalachia Mountain Health, where I'm the Behavioral Health Program Manager. Nice to share space with all of you.
Yeah, good to see you. Thank you. And I'm Autumn Fisher. I'm here with Appalachian Mountain Health as well, and I'm our Director of Behavioral Health.
And I'm Jody Rodwald. I am the Substance Use Prevention Coordinator with Jackson County Department of Public Health.
I'm Morgan Mathis. I'm the Community Engagement and Development Manager for Appalachian Community Services.
Welcome, Morgan.
I'm Marissa Bradley Ward. I'm the newly Western Region Administrative Assistant for Sunrise Community for Recovery and Wellness.
All right, well,
I'm Shelley Foreman. I'm the Community Relations Regional Director for BioHealth, and I work in Haywood County West. Okay.
I'm Bethany Riddle. I'm Opioid Settlement Coordinator for Graham County and Community Linkage to Care at the Graham County Department of Public Health.
Hi, I'm Megan Cruz. I'm the Director of Mental Health for Jackson County Public Schools.
I'm Wayne McMees, ICGH Treatment Centers, and I am a lead trainer for our peer support specialists to address an outreach opportunity.
Hey, welcome. I'm Chris Houck. I'm Vice President of Expansion and Strategic Operations for ICGH.
Melissa Howe. I work at ICDH as well. I'm Director of QA and Compliance.
I am Michelle Shibboleth. I'm the Executive Director for 5 Point Center in Graham County, which also operates the CHIO Recovery Community Center.
I'm Misty Shope with 5 Point Center in the Program Development and Community Engagement Manager.
welcome.
I'm Taylor Caton. I'm the NCKIT Community Health Worker with Operation Day Ray.
I'm Rick McCoy, and I'm representing with Hope. It's Harry Consulting Services and the Center of Smythe Jackson.
Welcome.
And my name is Tess. I'm the Advocacy Coordinator with Operation Gateway. I'm the person responsible for making sure that you guys be here today, and thank you so much.
Thank you. Thank you, Jess. So I just wanted to talk about what's going on in real time as we have this conversation, and then we'll have the discussion. I have in my hand right here Executive Order number 33. Josh Stein, it was issued in February. The legislature is meeting right now on a short session in real time, and what they're trying to do primarily is resolve unresolved issues, and that is funding Medicaid, passing a budget. North Carolina is the only state in the union that doesn't currently have to operate in budget. So if they don't get their act together, June 30th, we're in trouble. But the good news is that we have bipartisan agreement on Medicaid funding, $319 million to meet the Medicaid shortfall. So there is some progress being made. So this conversation comes at a critical time with what's going on behind us. So I will start by throwing this question out. Anyone can answer it. What is our most urgent behavioral health challenge here in Western North Carolina?
Really, I'm just curious as to what are the services in this area pertaining to that as of now.
Okay.
I mean, what are the main use services or providers?
Appalachian Community Services provides behavioral health and substance use services for the 7 western counties of North Carolina. We have walk-in clinics in 6 of them where we provide
basic outpatient therapy, medication management, substance abuse intensive outpatient program. We also have state-funded enhanced services such as community support team for adults, intensive in-home for youth. We have the 24/7 mobile crisis line that's available for everybody. And then in our Haywood location, known as the Blossom Center, we have the Adult Recovery Unit, which is a short-term inpatient facility-based crisis unit for detox and stabilization. And then that co-locates with, it's fairly new, it opened last April, but it's the Behavioral Health Urgent Care. And we've got 6 youth beds and 6 adult chairs as a 24/7 crisis walk-in center.
I was just going to state the main challenge, I believe, is substance use disorders and co-occurring challenges that develop around that. And then community supporters, networking together, such as what we're doing here today, exchanging services, opportunities that we each have to offer, and then just networking and just being able to address the issues that's within the counties and the population and the cancer that we all serve. Okay.
And I'm piggybacking off of that. One of the things that our community has is like a wealth of really wonderful, incredible service providers, and each does not have enough clinicians or providers out there and enough staff. And when we get funding in this region, it goes like maybe in one spot with one organization. And really, like as a community, we need to grow collectively together with all of our organizations because we all do incredible things in the community that's valuable to the populations we serve.
Yeah. Yeah, I to answer your question, the most urgent behavioral health challenges. I work in the public school system, supporting therapists, social workers, and counselors, and so my focus very much is on children and families. And we are seeing just exponential growth in the number of young people that are hospitalized due to behavioral health and substance use related challenges, far more than any other generation. All of the research and studies currently are telling us that Generation Z is statistically much more unhappy and more likely to receive behavioral health treatment or need behavioral health treatment than any generation prior to them at this current life stage that they're in. And they're predicting similar, if not worse, outcomes for our youth who are our young people today. And so providing intervention early is so critical, and we know that they are struggling. And workforce, we create opportunities, and we can't necessarily. I was just talking to Graham County here. We were talking about how to get people to come and work west of Asheville. That's sometimes challenging, and we partner a lot with Western Carolina University. I have partnerships that I've grown with University of South Carolina to replicate some of their workforce things that they can, but then there's not always supervision capacity. If we can get interns growing in the substance use track or in the mental health track, like we don't always have people locally able to provide supervision. And so really trying to strengthen that pipeline so that then when we have collaboration and connection in the community, we have people to fill those positions. And I'm a big proponent of school-based mental health because it eliminates so many of the barriers, which maybe we're going to talk about in a minute. But yeah, I think it is a challenge because we do not have enough to meet the needs that are growing.
And I think that's exacerbated. I look at Bethany and Graham County, it is so remote that it's really challenging. While we have great providers, I look at UADA with the Tallulah Clinic and ACS, but the ability, they have a service array, but then the ability to maintain the staff, we talked about that at our last meeting, they may be able to do something, but as soon as they lose their staff, then they start all over trying to look for someone else. And I think it's more exacerbated the more small or remote the county is.
Sure.
The thing with Grace Hope, we agree with that because of the staff. You have longer wait times, so you get people into the facilities to be on for stays. We have that. Like we have people on the list that want to come to us, but they have to go through these programs to get to us, and they're on the waiting list. So that really hurts, and some of them go back out doing what they're trying to keep them from doing substances. So that's a big problem, wait list.
And I think that's exacerbated. You're very lucky if you have Medicaid, right? We all, if you can get Medicaid, wonderful. That helps with what is available to you. But we have many people in the far west, even with expansion, that still have no insurance, especially those with substance use disorders. And the state over the last 15, 20 years has continued to cut the funding available to serve people with no insurance. So it is incredibly hard for our providers to be able to meet the needs of a population that where there's no funding or inadequate funding to meet those needs.
One thing that I have been seeing lately, it kind of ties in with what you said about the budget, but the new work requirements for people that have Medicaid and food stamps. I have clients that are losing their Medicaid and food stamps because, they're using drugs and they may not be able to work or they may not be able to volunteer. And then on the work exemption forms, it's very limited on who's able to sign it. And then Medicaid only lasts for 6 months when it lasted for a year before. So a lot of problems with those folks losing their Medicaid and food stamps.
So if I could reflect back, it sounded like there's not enough funding, not enough staffing. The situation gets worse the further west we go. And then some of the qualifications are disqualifications, really, like the work requirements. In terms of, thank you for providing those numbers. Do y'all feel like there's enough beds, there's enough services, there's enough to meet the demand?
So, that's been an ongoing issue.
I've been doing this for 25 years, and it has been ongoing probably since 2001. We've seen the transformation of Medicaid, then the transformation of Medicaid, and then the transformation again. And we throw everybody in some kind of cycle, and we get stuck in that cycle over and over and over again, expecting different outcomes. It's always been about funding, not enough funding. Like we used to have IPRS funding, and we could do so much with that for the population. But as they continue to cut the budget, but then they expect the need to be met, that's impossible. You can't expect providers to do that because the overhead for us is growing every single year. The budgets grow and grow and grow. We need workforce, and the workforce pay comes up, and you're trying to meet all this demand, and you have a massive shortage. They just said that we're in the worst hiring market since 2009. You cannot hire people at critical stages. We're at 40 some open FTEs currently in our organization, trying to bring people in. So I think it's a constant transition, and I was actually thinking about when I was coming up here, thinking about you hire someone in, you train them, you get a client or a consumer who comes in and they get very attached, and that therapist is making change in their life. But then the rotation of the workforce now and in the cycle that we're in, people move in 6 months. So then you get instability. So then you're trying to reconnect this client who's made such progress, who now has to switch to another therapist, but it's almost impossible because this therapist has a 6-month waiting list. And so to me, we've over the years, I think we've done great things with the BHUCs and the facility-based cross. We need a lot more, and we've definitely forgot about the adolescents in this process. We do not have enough adolescent care throughout the state, beds and those kind of things. Even PRTFs, we have to transfer kids out of the state to put them somewhere to be safe. And so for me, it's the providers get siloed. We can't help it because it just happens because everything's always changing for us. And we have a hard time connecting out because in 25 years, I've never seen in behavioral health us be able to be proactive because the system creates us to be reactive. And that's how I feel, Wilt.
Okay. what are the problems driving retention, or just hiring, being able to hire in general?
I think hiring in general is what I'm seeing on our end, and what I've seen for several years. And before this, I was the president of a pediatric company, and we hired nurses, and that was almost impossible. The rate of pay went up so much after COVID, and you also had a lot of nurses exit the system. So even for us, we have nurses in ICGH, and they're so hard to come by. But then the therapist, you have to put so much in recruiting. But what we're finding is it's a lot of it's got to do with the pay. So think the funding that we get, but we see a lot of times. I'll talk with someone to come in, and they want $80,000 a year, fresh out of college. Well, that can't happen. Yeah. I'm sorry. And I'm not being negative about it, but I think we've created an environment for that, and it creates a very difficult place. But it's almost you can put 1 million ads up and spend the monopoly of Indeed $20,000 a month, and you're going to get 3 hits on one ad. I mean, when I reach out to other colleagues and I say, in other sectors of Medicaid, are you getting any applicants? And everybody's like, no, nobody's applying anymore. So, and I think you're in an economy where people are scared to move jobs, and it's kind of scary getting in more to that public mental health space because it is a constant shift. I always tell staff who want to come on, I said, if you want something that feels sometimes stable, you're in the wrong field. There's no stability about it. It'll change every day. There's no consistency. And that's part of our problem. And I think behavioral health, and I used to do IDD services too. There was no consistency. There's too much change all the time.
And to your point, and I think the pandemic highlighted it, I think technology was moving along, but the pandemic made it possible. And Medicaid now, in many insurances, you can bill through virtual and telehealth. And so there are many large behavioral health organizations where a therapist can get hired on. In North Carolina, they may be seeing clients from anywhere. They just sit in their office in their home and can see patients. When you're talking about the work we all do, we're talking about community behavioral health. We're talking about the people with the most challenging mental health and substance use issues. We are talking about people who can be challenging to engage and stay engaged. And I don't think there are many clinicians especially who say, yeah, that's not for me. And then if the pay is not competitive, then that's like a double whammy. So community behavioral health is a lot harder than working with, I guess we call it the worried well, not to diminish their issues, but it's different than who we serve.
You didn't bring the recruiting perspective, though. The cost of living in Murphy and Robbinsville is equivalent to the cost of living in Asheville. It is very hard for us to find people who can move out there because housing is so expensive. And we have bumped our salary to meet the $80,000 a year for a new graduate, and they still can't afford to rent or buy a home in Robbinsville. That's how expensive housing has gotten in these regions because we have people buying 3rd and 4th homes. So that's an additional barrier for us to recruit qualified staff out here is they're going to find somewhere where they can afford to live.
Absolutely. And then when you look at the cost of licensing fees, training, all the things like that, there is limited support for that, and clinicians oftentimes have to come out of their pockets for that, right? So that we also want to consider that until we are factoring in what people request when they're asking for pay, right? We're coming out of school with student loans too. Oftentimes they have to start BDK, especially right now, pretty immediately, right?
Immediately.
Yeah, absolutely. So there's a lot of different factors that come into play when it comes into retention of clinical staff, but we are seeing a mass exodus out of the field because also you're looking at behavioral health providers who also need behavioral health support. And there is not a lot of support for us in that way.
I think the telehealth helps some people, but not all. Especially the young people, they want to have hands-on and contact. They don't want to be looking at a screen, talking to someone. Like you said, they can't be personal. They can't make that connection. So I think with our young people, telehealth doesn't always work.
Recover. So there's some agreement that telehealth is not meeting the needs of the acuity in this community. So I want to dig into the youth because that's not on my list, but it has definitely come up. And we're seeing that a lot with our agency. We have an emerging youth program because of the referrals that are coming in. So what's available to at-risk youth and youth experience crisis in this area?
So now, I know we heard from our Appalachian partners about a lot of the programming that they're doing. They within Jackson County Public Schools, we partner with a lot of community organizations. Like we refer students to Appalachian, and we refer students to Blue Ridge Health, which is co-located in several of our schools and provides community health clinics to our students and staff and families, as well as behavioral health. And we partner with other organizations like Heights as a local nonprofit that is really leading the way when it comes to substance use treatment and workforce and all kinds of other things with youth, and really kind of homegrown grassroots folks. And then the other model that I can talk all day about is school-based behavioral health. And so Jackson County Public Schools received a SAMHSA grant called Project Aware in 2019, and it was a 5-year grant. So 20 and 21, and we're in our final year. And with that, we were able to do tons of training with our school staff. So with all of our teachers and our behavioral workforce within school, and we were able to hire a number of clinicians that are providing outpatient therapy services for students referred to them at school at no cost to the family or to the schools. And that model, I just think that that's how we access youth, is by going to where youth are. And the majority of the young people in our communities are in public schools. And so that eliminates barriers like transportation, parents having to take off work. It reduces stigma because it's at school and you're not having to go to another office. And so we really prioritize students who would not otherwise have access to services if that was not available in their school. And we refer vast amounts of students to our other community partners because it takes a combination of approaches. But that is a model that we have worked on replicating in Swain County. We helped them obtain a grant from a local grant-making organization, and they've hired a clinician. We have been working with several different districts in the West to try to replicate some of these school-based programs, but without sustained funding. Like we're working on learning about school-based Medicaid reimbursement. I'm going to a thing in a couple of weeks to learn all about the state plan amendment and how we're going to make that work. But without the Department of Public Instruction in North Carolina making an allocation for school-based clinicians, that is not something that districts like Graham County Schools or other small districts are going to be able to sustain on their own. We're fortunate in Jackson County that we have county commissioners and local funds that they're putting toward sustaining this program, but in other counties, they don't have the same amount of resources or the same amount of support.
So Megan, you and maybe Bethany, I'm not sure if you're part of the Systemic Care Collaborative, one talking about school-based services and trying to be innovative. We're lucky to have the Dogwood Health Trust, who is a great funding support to many of our initiatives. And I know in Cherokee, Clay, Graham, and Macon, that they put together a partnership where Heights will go in and do some work with students, but they're also working with UNC Chapel Hill to do telepsychiatry. So telepsychiatry is going to be available in those schools, and then we have a local provider who will do that wraparound. So I think while the funding isn't the same as Project Aware, that some of the schools are trying to get creative in how they can deliver services, because one of the things our providers have to deal with, if it's youth, kids go to school to about 3 o'clock. So, basically everybody wants an appointment from 3:30 till 5 or 5:30 or whenever the center closes. And not it's really challenging. And school-based services are really the best way to serve kids. So at least we see that expansion and growth in the schools.
You said Project Aware is in its last year of funding?
It is its final year in North Carolina, and to my knowledge, there's not been a new NOFO released by SAMHSA. SAMHSA underwent some changes recently that has reprioritized some of what federal funding is available. But we're still hopeful that there will be opportunities for additional funding.
Okay. What happens if that funding is not extended?
So we've been preparing for that for 5 years. Yeah, so right now the number of clinicians that we have, our school system and our county commissioners have very generously, we're able to maintain them. And we are going to begin seeking Medicaid reimbursement through school-based Medicaid. And so that will contribute to our ability to sustain it long term. But yeah, we won't be able to do some of the really big, amazing initiatives that we've been doing for 5 years because we're losing that funding.
All right. Let's look at section number 3, the crisis response system. What does that look like for your county or for the region?
It looked different county to county. So here in Jackson County, it went through our police department. We have community care program, so that we have one on-staff social worker that co-responds within SILBA, and she does co-respond within the county as well. But really, she works for SILBA because she works with the PD, and so their jurisdiction is really SILBA proper. But she does do so we're working on that initiative. We met in February with a lot of different organizations in the county to do a sequential intercept mapping training to establish crisis intervention team in Jackson County. And so we are starting that process. They're going to have their first training in May for a week for law enforcement and first responders. And so we're working on those initiatives because we've seen how well the community care program has worked. And that was an initiative started with Western Carolina University. And so that program is working fantastically, but she's one person.
One person, yeah.
And so she can't possibly address all of the issues that we have. But so that's what we're trying to put forth because we know how
Her core hours.
What are her core hours? I mean, she's really like a 9 to 5. Monday through Friday. She does go on call in the evenings and weekends, but you can't work someone that hard.
What's wrong? Absolutely.
And Jody, do you know, I think the community care project, I know they're behind Jackson, but Waynesville has one.
Waynesville has one. Murphy.
And Murphy does.
Yeah.
Perfect. That's wonderful. Yeah. So it's starting to catch on, but again, it needs to be countywide rather than just in Silva.
Okay.
There is a county-like co-response team in Cherokee County. ACS worked with VIA. I want to say it's brand new because it just started this year. But we have embedded 2 clinicians in the sheriff's department to co-respond with deputies and provide follow-up with that care. But it's not 24/7 either. It's Monday through Friday, 7 a.m. to 10 p.m. with the 2 clinicians that we have. But it's also been a great resource for those in Cherokee County, and there's a hope potentially to expand others to happen.
Yes.
Ahmed, and your board program again?
Well, then,
Where does the crisis response system break down? Where does it break down?
I'll say that in Graham County, a lot of times we'll have someone we'll call the crisis center. And then I've had a couple of people where they basically said, we can't help you because maybe the person was on a medication or has some other issue going on. And it's kind of hard when you call the emergency response line for an emergency and then they're like, sorry, we can't help you. I mean, that's hard, yeah.
That's very good point.
Okay, so you said maybe medication reason, but why would someone engage a crisis response system and hear the word no, right?
That's a continuous issue. And I know ACS is working on it, and hiring someone in mobile crisis is almost harder than hiring someone for community mental health, but sometimes the response isn't what you would expect. So what happens is if they can't get an immediate response, you're forced to take someone to the emergency department. And the emergency departments in our region are fairly good about understanding that. Unfortunately, like Graham, you don't have a hospital, so folks are traveling. Folks can go to the behavioral health urgent care, but there's only one. Funding those units are incredibly challenging, so
Well, I can speak on the issue of our behavioral health urgent care. It is not a medical facility. So there are going to be co-occurring conditions that can put someone's health in danger that we are not equipped, to work with. So at that point, there might have to be a cause for them to go to the emergency room. And that's not at all what we want them to do, but for their safety and for their health. That's what's going to have to be the next step, at least for them to be cleared by the ED to then come back and work on those crisis services. But then I also wanted to speak on where we are location-wise as a gap for crisis services. It's time-consuming to get to someone in a crisis. It's very time-consuming, and we spoke on staffing and how that's an issue. So imagine you're already short-staffed, and your mobile crisis assessor is in Haywood County. The person that called and is in a crisis is in Murphy. Imagine doing that drive, and maybe that drive would be okay if it weren't for you're going to lose service 4 times between that drive. And so even if someone stayed on the phone the entire time talking them through that, they could try their hardest and the call's going to drop. And then what happens in that call? What happens in that dead time? There's so many logistical issues that cannot be fixed because of the rural location. And with the short staffing and not being able to put a mobile crisis assessor in every county, in every town, it leads to a long wait time to get that assessment done.
Yeah. And I would just add to that and reiterate what we've said before. There are not enough beds for young people. Like our students, when they do end up in the ER and need an inpatient spot, they sometimes hang out in the ER for days and days, sometimes weeks either.
And then they go out of region, out of state.
And then they go out of region, out of state more often than not. And we're thankful that they do eventually go somewhere, and we are thankful when they return to us. But there's also often a breakdown of communication between that out of state or even local placement sometimes. Then the student sometimes just shows up back at school, and we didn't know they'd even been discharged. And so there's no warm handoff or safety planning or recommendations made or team meetings. And that's a goal that we've been actively working on, and we have lots of great relationships now with providers. But that, if it could be systematized in a way where school, it's at least a part of the conversation when students are coming out of hospitalization, that is a breakdown.
And I will say, I know for us, and this is not local, or we're getting ready to open a 40-bed adolescent unit at the coast. But we're also looking throughout the state to open more adolescents bed. That's become a big thing for us. And it's something we're researching with the MCOs to find. We're in the hunt for multiple facilities to be able to really focus in on adolescents. That's one thing sometimes I just think has been forgotten. And knowledge is power. And I'm going to go back to school base. School base is one of my absolute favorite programs that we start young, work with the kids. And then when you get into rural counties, if you go more, metropolitan, like Wake County, I think they're the 10th largest school district now in the United States. They have enough funding to run programs like that. There's enough funding in-house to run programs for these kids, and they're able to do that because of all the funding they're getting due to their size. And I think we forget the rural counties that they don't have that kind of funding that the metropolitan have, just like losing cell phone service. I know Mecklenburg County has a service where therapists, when the police go out, the therapists are with the police force. But then again, when you start hiring there, you've got the bigger pool of the metropolitan areas to pull from. When you get in the rural counties, you're right. The cost of living here is, some of the housing here is
is very, very expensive to be able to move here. So I think that all plays a part. And but I think with the adolescents, we need more beds. We all know that we need more funding for the beds to be able to support these youth. And having to take them out of state or pull them all the way across the state is too hard on the families, because it's difficult for the families to visit. I mean, you're 6 hours away, or to be able to visit, and that also puts it hard on the kid being that far away from their families. So I think that's something we just really need to focus on in the state at the next, especially with the next sessions that come about, is what are we going to do for the adolescents? Because if we give them the knowledge and the power and the resources at a young age, then we're able to change and create generational changes forever. And it's like I tell our therapist all the time, and they get tired of me saying this: if you help one person in your entire career, not only help them, you possibly created generational change so that 300 years from now, you changed generations of people. And I think sometimes if we sit and think in those terms, what are we doing? Okay, if we can change that kid who's in that place in life and doesn't have those resources, we've changed family on top of family on top of family on top of family. And I think once we can get there and see the bigger picture, more about did we hit our outcomes? Yes, we hit our outcomes, but where's our billing this week? Where's the denial rate? What's our denial rate? What's our KPI reports? All that's very important. But we all entered this field for one thing, and it's to make change. And that's what we're here to do. And I think doing what the school-based therapy is where we really need to start, and then opening more beds for these kids.
I wanted to point out when we were talking about all the barriers that you were talking about, Morgan, when you have someone who uses substances and they're in crisis right now, and then they have to call this person and wait, and then they have to go over here and they're told no.
Yep.
It's by the time like that goes for a few hours, they're like, never mind. Or even I've had some where they would talk to mobile crisis and they would get them into like ADAC or something, but they're like in 2 weeks. Well, in 2 weeks, we might not even know where that person is anymore.
You miss the opportunity that presents itself at the stage of change.
Right.
They go from an action stage back to a pre-contemplation stage. Right.
What's the current ED? And I'm just asking for those of you who work, deal with the hospitals. What's the current ED wait time when we have someone there on an IVC for turnaround?
So IVCs, and you guys do mobile crisis. IVCs, obviously, what happens is someone will go, and it varies by hospital because you have Erlanger out your way, and then Harris, and Haywood. Haywood, actually, I just found this data out like 2 days ago. Haywood Regional Hospital has an adult and a geriatric behavioral health unit. 50% of the admissions into the Haywood Behavioral Health Unit are because of involuntary commitments. So that's a pretty seamless process from any of the hospitals. The problem is that many times they go in and the commitment is broken, and they're just sort of like, okay, bye. And they're turned out of the emergency department with no one connecting with them. I mean, they literally might just leave. If they do uphold the commitment, it's typically short term. They could be placed anywhere depending on if they're Medicaid or state funded. As you know, getting into ADAC or Broughton, talk about staffing challenges. The state programs are just, there's really struggling. They could have more beds, but they can't because they can't staff them. But it's like a revolving door. They may go in if they may get placed in a residential treatment, but by the time they have that first exam, unless they're pretty significant, they let them out. Because many times, and I don't mean to be this derogatory, this is what I hear from our care managers and many of you who are working directly with people, is that people learn what to say. Like they're saying, oh no, I'm fine. I was just having a moment and I'm not, homicidal, suicidal, I'm fine. But that doesn't then, they just let them out versus, okay, let's do a transition plan and connect. I mean, that happens sometimes depending on where they go, but it gets really hard. But the hospitals want to get them in and out. Unfortunately, sometimes people get stuck in an ED, adolescents, older patients, people with complex special needs. They could end up in the ED for days because they can't find a placement, which is really challenging.
Say we see that at our hospital with the adolescents. They might be there for 3 or 4 days, and then what you were talking about, the distance, you have to remember a lot of these adolescents, their parents are no longer here. Their grandparents may be raising them, and the distance that a grandparent can drive, but sometimes that's a barrier. So a lot of that, but you're missing a whole generation in a lot of these adolescents now because of all the overdoses and people still out there using. Yeah. So that's a real barrier, getting our adolescents close where their grandparents can see them or getting back to one year.
For me personally, just like Ruth said, like from our hospital, my husband has his biological son has IDD. He's severely autistic and nonverbal, and he was removed from biological mother. The closest place for him is 3.5 hours away from us. So limiting, and it's a group home. Like we don't have places like they have in Kannapolis where he is here. And so getting him served here where he's close to family is none. Like there's none.
Especially if it's dual. I mean, autism is sort of behavioral health, and that can be. You're right. That's like the golden ticket if you can find a place that will take them, and it's really hard to find providers who will, instead of like, it's hard enough to find community-based services when you're looking at like a group home or residential. I mean, we could call for hours and hours. And the truth of it is many of our residential providers, especially adolescent children and adolescent residential, they can pick and choose. Even the highest levels of care, which things should take the highest level of need, they can say, no, we don't feel this is a good fit. So you have, clinicians, whether it's the hospital, whether it's our care managers or others, calling and calling and calling and trying to get those referrals. So it's challenging. And it's partly because of reimbursement for those providers. There is a new adolescent unit opening up. Pardee is opening up one in Hendersonville. There's a new one. It's called Blue Rock, which is really cool. In another, it's a Lake Floor area.
Bat Cave.
Yeah.
Okay.
And then, and Sweeten Creek. But, they're not necessarily specialized for dual diagnosis, autism, or for like we have geriatric population.
Part of serving kids is the staff. Kids are hard. They're hard to work with. And when they're challenging, they're going to walk. They're not going to want to work for $50 an hour. So when you have challenging kids who are dual diagnosed, staff don't always feel that they are adequately trained to work with them. They don't have to work for us at all. They can work anywhere else they want to, and they typically do. So we have challenging kids. We still have that child. We don't have to stand anymore.
Yeah. All right. It's not a bed, but ACS has also piloted a program that right now is only in 2 counties, but at the end of the summer, there's a hope for an expansion to Jackson and Haywood. But it's called the MOORS program, and that stands for Mobile Outreach Response Engagement and Stabilization. And in the short time that it has been in the western counties, it's been a great resource for Macon and Swain. It's one team, but it's a clinician, a qualified professional, and we have 2 family supports that work with a youth in crisis for 4 to 8 weeks to stabilize them, be able to refer them, provide them therapy. And one thing that's really neat about this program is the youth or adolescent, because it's for ages 3 to 21. Your qualified professional and your clinician works with that youth, but the family support works with whoever the caregiver is. So if that's mom, if that's an aunt, if that's grandpa, whoever it is, they can go out in the schools, in the homes, and work with the whole entire family on, growing independence, figuring out what the issues are, referring them, whether it's within ACS or it's to Heights or youth villages or wherever they need to go. And it's a small program right now. We're at our max of 15 clients, but that's 15 youth that were in crisis and didn't have a place to go, but now they do, and now they've got a support system. And me personally, I'm community engagement, so I don't work, directly with clients, but I can see a difference in ACS just because more came into our service line of what we're providing, and even how the community sees ACS because they see that we are providing that help as best we can for the youth and helping them grow. So I'm really excited for that to come to Jackson and Haywood.
What counties is that again?
Right now, it's just Macon and Swain, and hopefully by the end of the summer, it should be Jackson and Haywood. Yeah.
And for adults, one of the greatest, I mean, I'm sort of sitting cross-looking at Michelle and sitting next to Marissa. For adults, one of the biggest, I think, improvements and developments in the far west has been the rise of peer support. Whether it's, I mean, Bethany, your program is wonderful and has been a leader. Sunrise, through funding, has been able to work in the far west. They're doing work in detention centers. They're doing work. They just opened 2 new peer drop-in centers. Michelle, I'd love for you to talk about what you, I mean, you guys are doing great work in Graham, and that is what, I mean, that's the support to individuals that isn't a service, but it is probably more meaningful, and it helps people get to a service that they need.
I do. Absolutely. Yeah, we have a drop-in center, and we just opened a drop-in center in Silva off of Main Street. And then we have one on the Boundary, but you don't have to be enrolled to get service there. So that's the safe space in the drop-in centers in those 2 counties. But we do reentry peer support. We have a team of a male and a female that go into the ports and the jails and do reentry peer support. We have a team of a male and a female that are partnered with the Cherokee Hospital, and it's a wellness connector position. So if someone came in to maybe the drop-in center and they're like, we're ready for detox, they can help navigate that and also walk closely with them and, just be there as support. Like that might look like going to detox or going to the ED and sitting with them through that process until they get took upstairs, or however that looks. But like other people have mentioned, I am seeing sometimes like going to the ED like we've been told to in the past to take them to get to detox. It has not been the route that we thought that it was going to go. We've been told, yes, get them to the ED, and like this person's ready for residential treatment and never has been ready before. She could be my participant for 2 years and never wanted to do treatment. Now you're ready to do treatment. Okay, get her to the ED. We'll get her whatever. Oh, well, she doesn't need residential. She's had this little bit of time abstaining from not using. Okay, yeah, but where's the coping skills that can be learned in residential? Like, you can't. So there's definitely a disconnect there. But back to the peer support, we just meet them where they are, no matter what. And so we have that. We serve Jackson, Swain, Boundary. I mean, I live in Macon, so Macon. I mean, we're just everywhere. So.
And No Wrong Door is not here today, but that's another peer drop-in and peer outreach program.
Yeah.
Fire on yourself.
I was going to say the role of peer support community-based workers. How new is that and how established is that?
So I've been with Sunrise for a little over 3 years. And so Sunrise was established in 2016. So newer, but not new. Sorry. I've been in and out of the courts and the jails for the 3 years that I've been working. We actually get to go inside Swain County Jail and do groups. We're trying to get in Jackson. That's Especially
Mon Door is working in Jackson right now.
oh, they're based in Macon, so
They have a contract through the opioid settlement funding. I think, is it through the opioid? No, it's through the sheriff.
that's the share. They're due, but they're only there to work with folks that are on OPEP, which is a very small percentage. So
ICGH in Andrews, I didn't mean to jump on you there. ICGH in Andrews, we're relatively new here in the area, but I've been working with ICGH since 2018. And what we would like to see happen in this area is to, a couple of years ago, we opened up an office in a rural area. It's real dear to me, up in Wilkes-Barre and Yadkin. Much like this area around here, very spread out. People in the hills that's, affected by, ways and means of using more substances through several generations from moonshine to THC, growing weed, Quaaludes, and then the opioid pandemic hit and it just went out the roof. And so I went to my boss and talked to him some. We had ICGH in Hickory. When I first got hired, we had opened up an agency in Lincolnton and then went down to Gastonia and opened up an agency down there, started addressing those needs in those areas. And then I had the opportunity, we went up and opened up an agency in Dobson, which is a rural town. But through a mobile, started connecting with the community supporters in the area, and we're not a one-all be-all fix-all, but us collectively, the community supporters in the area, networking and working together. It's not my ball, your ball, but we got people that need help. We need to work together to try to meet the needs of those people. Okay, so with that mindset, try to engage with these community supporters, going out to different outreach events, different collaboratives, developing, working with those, getting on board with them. Surrey does now have a port, which is good, which a local peer support works with the local EMS, meeting the people out on those calls, and then getting whichever provider that the individual would like to get their services. That's kind of how they work that. But one of the most effective things that's helped us there was that we was able to start a mobile medical unit. I started with a bus, and then I've got these different places, these encampments, and where the individuals, the population which we serve are. Had some outreach bags, and they also had the material, the information that and the services that we had. And just like, some of the peers that already stated, meet the people where they're at. Let them know, come along. At shared lived experience is a very important part of what we're doing. And let the people know, hey, you know what? I've been there. I understand where you're at. I've felt your pain, been there, done that, and been in some of it. I want you to know that this program of recovery, which addresses, it's an integrated model that addresses the whole person, biopsychosocial, meeting all those needs. Hey, if this program can help me and give me a life, but I'm letting you know there's no one that should be left behind. And man, we're talking to people like that, and then their eyes light up. They start, and we've not been able to help everyone, but we've been able to help a lot. And I would like to see, hopefully, in the near future or in the future here, and serve Andrews and Murphy and Robbinsville, which is Cherokee County, Clay County, Graham County, and how we may be able to network with those in these areas as well, if there's any way. And then also at sea level, if any of you guys run across somebody, you can't get somebody somewhere, ICG, Carolina Wellness Center at sea level, if you'll give Misty or I or one of us at ICGH a call, we'll try to get them to where they can get into Carolina Wellness Center. If their insurance cannot get them there, we'll try to get them a bus ticket there. To get them there at the detox there, they can step to 30 days in the detox. It's not just a 7-day thing. They can stay in residential treatment to 90 days. They can go from there into transitional housing, which is next door, and then it's kind of like a re-entry incentive. They can come over, work some in the hospital, and gain a little bit of employment, where they start feeling, some self-worth about themselves. And then from there, they can go on to our sober living opportunities all over North Carolina, whichever one best fits their need. But we're not, we can't help everybody, but we can help some. And so I'm going to leave these here. I'll pass them out when we get ready to leave. But I really appreciate this set down, what y'all talking about, addressing the issues, trying to find out, pinpoint the challenges that we all have, we all face. But I believe the solution is us working together, us communicating together. And if I can't help somebody, maybe you can help somebody that I'm working with, and I'm going to try to give you a call and get them connected to you. But it's a team. It's a team effort. It takes a village to heal a village. Thank y'all. I didn't mean to talk to you.
Do you mind if I say something? So I wanted to talk about, so in Graham County, I was the first peer support specialist in Graham County, and I was the lead, and then I had another peer support specialist, 2 different ones that are really, really good. But it's kind of the same thing. They could make more money somewhere else, so that's what they did. I mean, and I picked them for that. But also, a previous health director of ours, the one we have now is great, but a previous one, it was her idea to have us start community linkage to care plus post overdose response team. And so we secured, letters of support. We created the protocol. We got the funding. We, began to implement the port. But in Graham County, stigma and politics has really made it where,
Especially lately.
yeah, has made it to where the port isn't what it could be.
Nope.
Because, if I'm the only one on the team that's working towards this goal, then, the team's not going to work. So I have tried to look at ways that I could still, make a difference in the community without having a port team, because say if your EMS isn't going to give you any referrals, I mean, how are you going to get referrals? And even down to data, even getting data is almost impossible. So yeah, I mean, that just goes to show you can have a great program, you can have great employees, and you can have the funding that you need, and it still gets shut down due to stigma and politics.
Yeah.
When even working with organizations that we struggle to have capacity to be able to accept new referrals, and we can't get MDs out here because even our MDs that we've recruited have had trouble finding housing in Graham County. So just getting that support in terms of funding for staff regionally in these locations, or supporting the qualifications for the staff that are already there that could grow, has been a huge challenge and a barrier to be able to continue to work the way a port team should work.
Absolutely.
So do you think,
I mean, you've lived through it. Like you said, you have worked. Yeah. And I see, I've worked in the far west for so many years, and I think we're making improvements, but then it's like you go 2 steps forward, 1 step back. And so the acceptance by first responders, law enforcement, EMS, our local governments, county commissioners, there still is a stigma around things such as harm reduction.
You can't say syringe
Don't even say. WinCat is great. We have a wonderful harm reduction agency that serves a lot of the counties in the West, but that stigma is still, I think, hard to break through. We've made some strides, like with the community care project now in 3 counties, working with the police departments, with the co-responder model, and it being so successful. I mean, we got some data yesterday about the people that are not going to the ED and not getting arrested. And so I think that'll change the tide, but it's still you feel like it's a constant battle to get everyone engaged and supporting, especially people with more significant behavioral health issues, mental health, or substance use.
Absolutely. And the unhoused population, going back to what I was saying before about the Medicaid and the food stamps, a lot of the unhoused population use drugs and they're, losing their Medicaid and food stamps. But the unhoused folks are, seem to be like, that's fine, but like not here, Yeah. Like that's if you help them and all that, but like we don't want to see it and we don't want them, here. Um, and it's really, really hard. And I've been working at this job for over 5 years, and I will say we have helped a lot of people. I mean, the amount of people that we haven't helped is more than the ones we have. But even if it's just, like you were saying, just one person, and it's been, many people. So I do think that we made a difference, but it's still far behind where it should be. Yep, where it needs to be.
Can you let that sink and hold for just a second and let me reflect back so that I understand what you just said? In Graham County, you believe stigma is an issue and it is even reflected in the referrals that you get from emergency response that are related to post-overdose and your ability to find those people and serve them with peer support.
100% correct. That's 100% correct. It is not just Graham County. It's not just Graham County.
Some places get better with what we're doing, like meetings like this. As an incentive, there's a county close to us, Alexander County. We started delivering service to them. They had no funding at all, and they weren't even part of our catchment. But our catchment opportunities was around them. So they, if you're, they may be in Alexander County, but if they're unsheltered, unhoused, they could very well be unsheltered, unhoused in Wilkes, unsheltered, unhoused in Catawba, unsheltered, unhoused in Iredale. Just saying that. Okay, so with that, we would work with whoever we could work with because it's unsheltered, unhoused. They started a collaborative there, and on their collaborative, they have local law enforcement. They have someone from the detention center at their collaborative. They have school boards, school members, people that's in the local high school, part of their collaborative. And Alexander County developed their collaborative with local EMS that was actually, and then they created their own peer supports, and now they don't need actually other agencies because what they have is they work together and they create their own type collaborative port to where they meet the needs of their county. If someone ODs last night, they're gonna have help today. I mean, Johnny on the spot. They worked together. It took them a while to get that to where it developed to where it was at, but they pinpointed the challenges. They addressed, not only they came up with a solution, then they put that solution to practice. And I would encourage any of you that if you're able to connect with Alexander County and Taylorsville, their port post or substance use collaborative, I would encourage you to just go up there and just sit with them through one of their meetings, maybe talk to them guys, because they've been through the battle and to me, they're the greatest model that I have seen as far as the community collaborative addressing and meeting a need and getting a job done. And they were just, they didn't have anything.
We have Substance Use Coalition, and all the people that you're talking about are invited. Most of those don't come. Some of them do. And it would work great if people would cooperate, but they don't.
Yeah.
And I spent a lot of time with like Buncombe's port and like a lot of time talking to Stanley County's port. And it works because they have support of the people who they need their support, county commissioners or,
Right.
Directors of departments and stuff like that. If you do not have that, then you could have everything else that you needed and it would never work.
Sure.
I do want to touch on that it's not just Graham. Like we, as Sunrise, we had tried to find a building or just location for drop-in center, and it took us 9 months plus just to find a building because we would find them, and yeah, it's great what you're doing and we support it, but not here. We don't want it right here. We don't do it in it. So county. The stigma is it's not just for.
So I'm wondering what it would look like if we called in more peer supports of community health workers. I know we talked about like pay to the staff and all of those barriers. But yeah, but you call what'd you say? Call the police.
Call those because that's where we need the backing. Like we need people supporting us. Like she said, if you don't have those people that are supporting that court team, like I didn't wake up to be a person with lived experience. I didn't wake up and think I'm going to be a needle junkie for the rest of my life. You know what I mean? Like, but it happened. I had trauma happen, and it happened, and I dealt with it, and I overcame it. And I think that what I'm doing now, if I had that back then, maybe I wouldn't have gone that far, right? And so I'm almost 10 years sober. I've graduated from college, buying a house, a law, you know what I mean? Like, and I know that if I can do that, everybody else will be.
Absolutely. Absolutely.
But the support that we need is not given because people don't look at us like the clinicians or the other people that, didn't go down that road and didn't go down that struggle. So you need those people in these rooms. You know what I mean? Like, we need those people to hear the stories and to see, like, I have so much support in Swain County. With the new sheriff, I went to school with him, so he watched me grow up. He watched me not make the best choices, and he watched me go to federal prison and state twice before that, you know what I mean? But he watched me come out, and he sees the work that we're doing right now, and he's like opened the door for us. And so we're in the pods, we're in the jails face to face with these people, and I think that's where the connection's made, and the long-term connection, that's where it's made. And if we had that support in every county, maybe we could decrease some of this, you know what I mean, some of the crisis, and focusing on the adolescents. I have children that went through all of this with me, and coming out and teaching them what I should have been teaching them when I was unwell and I couldn't.
Do you feel like, so Graham, all of this area in general, do you feel like I heard at the beginning coordination of services? There was a lack of that. So do you feel like a sequential intercepting mapping session would be good for this area so everyone could see what there is and where those gaps are?
Yeah, we just land in Jackson. Yeah. So we did February in Jackson. So we're on the road to that.
To going, okay.
Yeah.
FIA offers that as something. We do training, and we actually have several counties who you've inspired. So, it is good, but you have to, the sequential intercept mapping is like one thing.
It's one thing.
But we have a Jody. That's the other thing. Is some of these initiatives is who is going to move it forward. And so, yes, there's a plan which involves multiple agencies, organizations, systems, but it's like now moving it forward is, yeah, but we know you'll do it. So, yeah, there's interest.
But also, yeah, just like that, but that's Jackson. So the Qualla boundary is made up of Jackson and Swain. And if we're not collaborating together, and Graham, yeah. So if we're not all at the same table, what we're doing here might be great, and what we're doing here might be great. But why can't we get all on the same board?
Right. Absolutely, it's great.
So also land that we said we were inviting stakeholders, a big part of the stakeholder community, which would be law enforcement, first response. What about community supervision? I'm going to shift, so I'll raise my hand. I'm also a person with lived experience overcoming substance use and incarceration. So moving on to the public safety aspect of this, when people come home from incarceration into this area, what resources do they have? Are we supporting them? Where are we at?
I heard that. Yeah. And I do work very well. Like, it's not.
Yeah.
I do work very, very well, especially with Jackson probation supervision. Like we have a really good rapport as well as Wayne. Um, but I think they experience probably the same level of burnout, if not more, that we do because their caseloads are so heavy, but there's not really rehabilitation and supervision, right? Like,
Well, like VIA has a reentry program from prison, not from like county gas detention centers, but you can have, like you said, you can have a program and everybody thinks, oh, Buncombe County is so expensive to live. I know this has come up several times before, but I mean, the barriers for finding, so somebody's coming out of prison, finding them a place to live, getting them connected to services and supports, finding them a job, you know, is just so many issues. So it's just really hard sometimes. And sometimes people don't want to come back to where maybe they left.
Most of the time they do that. I mean, I find most of the time
That's a good
they want to come and be where they're from, and that's not good.
no, that
Yeah, like, well, if they can be supported, right?
Right.
And a lot of those referrals to those agencies, correct me if I'm wrong, they have to come before they get out, right?
well, or
Can they get into the VIA program if they're already released?
for VIA they do, but like we have all these other supports in the community. You probably don't know, or you don't know until they're back.
And I've even asked at the jail to be notified. Yeah, like I'll take my phone because a lot of times if people are sentenced or whatever, they'll let them out at midnight. And I'm like, I will come to them at midnight, but they say, oh, well, we don't know. People could get bonded out. We don't know how long they're going to be there. Yep. And then when it comes to probation, I mean, there's been some good relationships I've had, but to tell a super quick story, I had this person and they experienced an overdose, and they got more well than they were, and then they called mobile crisis, right? And mobile crisis was going to line them up a bed, and so they were supposed to go to ADAC in 2 days. So they went to their probation officer and they tested positive for marijuana. And that probation officer, instead of waiting the 2 days to let them get into ADAC, arrested them and put them in jail.
But is ADAS even going to take them? It's just marijuana.
No, ADAC will take them. Like, it was already set up that, ADAC was going to take them. It was already, like, in the works. They just said, hey, come Tuesday or whatever.
Oh, okay.
And then this person tested positive. And, they could have waited 2 more days and let them go to ADAC, but they did it. Violated them.
I think one of the gaps we see too is we do see services for folks coming out of prison that sometimes get lined up, but coming out of the jails, we actually don't see a lot of services that get lined up in advance. And some of them may have spent a significant amount of time in the jail. And there are less resources inside jails than there are inside prisons.
Yes.
And then when they're rotating in and out without resources, it's really hard to keep track of their care over time. So that's like a huge gap area that we see in the various counties we serve.
And that's what we try to bridge the gap of when we're going in the pods and making those connections, and we'll go ahead and get you signed up with an intake, and let's create a plan. Like, what is your plan? Like, I have a girl in Swain County right now, and she's working on 3 years sitting there, and she's still waiting to be sentenced. But like, we have a plan, like for when she's released. I have short-term people that, they might just have a 30-day sentence. I've got one getting out Monday, but she knows if her grandma or someone safe is not there to pick her up, she can call and I will be there to pick her up. So we have tried to work it with Cherokee. It hasn't gone as planned as we would have liked. But like, when we have those people getting released, to call and let us know, or to arrange a time and not just turn them loose at midnight. Like, if you're going to release them, let's release them at a certain time of the day. Like 5 o'clock, even 5 o'clock p.m. You know what I mean? Like, let's to coordinate that, but it hasn't.
I've heard too that the tribe is doing really innovative things in their jail, like medically assisted Yeah,
in my area, and they have behavioral health, and they have. We're actually supposed to start going in there after maybe May. We're gonna start, so we will be at Swain and Cherokee.
So there are maybe some more resources there on the reservations.
Yeah, but you're fortunate on the boundary if you're enrolled.
Yeah.
But if you're not, you're not.
But once you come out of jail, then it's housing.
Yeah.
Oh yeah.
Yes.
How they never lunch.
So, I mean, they might be ready to come out, but where are they going to go?
And that's my biggest fear.
And that's why Caleb and Caitlin created the transitional home, Res Hope. Yeah. But it's the funding. It's the
The
funding.
tribe has great programs, though, right? I mean, really, the tribe, you got the tribe is the gold standard here for a lot of the work they're doing with behavioral health, with social determinants of health, with healthcare.
Transitional houses. Also, they got a men and a
Yeah.
women's home there.
And they have a treatment facility, detox and treatment.
Yes.
So if we had that in every county,
We just need more housing because it's not enough houses. Yeah, I'm not
no, it's like 8 or 10.
Only via Medicaid members can go to Anna Lanischke. We have a contract, so, and non-enrolled adults, they just can't be an IVC.
I didn't know that.
Yeah, what about youth?
Pardon?
Youth with via Medicaid?
You have to have VIA, I mean, we're the only one contracting with them, so our VIA Total Care members they have to be an adult and a voluntary admission because they're two different court systems. And Anna Lanischke will take our Medicaid plan members, yes.
I'm wondering what it would look like with reentry if we viewed reentry as a healthcare issue instead of a systems issue. With NC Fit, I work that program and I'm a community health worker with it. And I think that I'm able to serve people who have been in jail and they come home from today 2 years before, right? And so, or prison. But we also provide all of those other services as well for them, like the rental assistance, the housing, the transportation. That's a big one. I found that a lot of people come home and they are suffering from post-incarceration syndrome. They don't even know how to communicate with people. And they need that community health worker or peer support there to bridge that gap. They're receiving mass services within prison. They're released to their county and they say, what's next? I'm going to go back to what I knew. And so as the NC Fit community health worker, I had their information before they even come home. I ensure that they are at Mayheck. We just partnered expansion with Minnie Jones. We're doing expansion with Appalachian Health. So I'm really excited to see what that would look like since Appalachian Health is already in this area, how we could get services out here to ensure that people are okay first internally and their wellness is first, because until that happens, then everything else is just going to be chaos, right? And their family's not going to want to deal with the same things all the time. So I don't know. I'm really excited to try to introduce that into this.
Is everyone in this room?
Operation Gateway up NC Fit.
Okay. Is everyone in this room aware of NC Fit?
I was.
Okay.
No.
Let's do a high level for NC Fit for everybody.
So NC Fit stands for North Carolina Formerly Incarcerated Transition. And really it was put in place just to ensure that individuals receive continuum of care when they come home. So since the prison system has adapted the MAT or mild treatments recently, people are getting dosed within the prison system. They are not, they may have been actively using little bits of buprenorphine while they're in there, but they're getting these doses at an abundance, and they don't know how their body's going to react. And I have found when working with people in reentry, it's either working for them or they're having a lot of side effects, and I need to get them a medical appointment immediately. And not only for your MAT and MAT treatment, but also to ensure the individual is okay however long they've been incarcerated. So I walk hand in hand with them and I coordinate all their medical services. If they feel like they are not able to communicate with the medical provider, then I'm there to do that as well. And really, I'm just a support system. I'm bridging that gap.
Yes, I just said there. The School of Medicine under the school.
Yeah, the University School of Medicine. Yeah, it is.
And it's a pathway to resources, but also
Yeah.
a community, a dedicated community health worker, right?
Yes,
Okay.
absolutely.
And we have two FQHCs in the 7 western counties. We have not only Appalachian Mountain Community Health, we have our Appalachian Mountain Health Center. You guys keep finagling your name. But we have Blue Ridge Health. So we're lucky to have those two resources.
I will say, and I hate to be, I'm not picking on anybody, I promise. But for instance, I just talked to Jennifer Jennings. Is that her name?
About
Yeah.
billing.
Yeah, I talked to her about that. But what she did for us is she found out, exactly who at Appalachian Mountain Health is prescribing Butte, right? And then she said, it's, this person and this person, but they're at full capacity and they cannot accept any more patients. So then what does that mean in Graham County,
We're looking. Well, yeah, I was talking more about health because you do have more primary health, some capacity, except in Graham. I think what are your numbers in Graham? You serve like what percent of the residents?
We're 170%. Yeah,
Yeah.
because there's no hospital. There isn't urgent care. Sometimes walk-in clinics.
Yeah. Oh, okay. Yeah. I wonder what the difference with that would mean.
Their model, how they, yeah. When they can, if you're an urgent care, you're essentially saying you can come in, we'll treat you, and there's these levels of care that but at a walk-in, it's just if we have availability, then you can wait. And
Probably has more to do with billing than anything.
we're not sure
Usually that you find it to be true.
but they've been trying to correct that they are an urgent care in the community. They are not an urgent care, they
I
said.
mean, it's really unique in Graham County. I mean, because we have Bethany who's been doing the work for quite a while. And then we have our organization that's been doing the work about going on 4 years now. And just because of the remoteness and the location, the chronic poverty, all the other things that are going on in people's lives before they ever get to the point of being addicted or having substance use issues is, just compounds it. So, and then of course, peer support and even Bethany's position are grant based. They're not. We don't bill Medicaid for our services. We don't have billable services for Medicaid. So there's no revenue coming back for organizations like ours to do the work that we do, although the work that we do is desperately needed in the communities where we work. And there is nobody at this table that likes having to chase their paychecks all the time. Nobody. Because that takes all your time and effort away from the work that you really want to and need to be doing. So it's compounded in Graham County because we're like the appendix of the state.
Yeah. Well, Michelle's correct. I mean, like my program was being grant funded for 5 years, but like our Dogwood Health Trust grant runs out June 30th. And so essentially, if our technical assistance person is not able to secure grants, then I'm not going to have a job. And, in the beginning, that first health director that hired me, the idea was that we would get grants up front, and then eventually the county would see the need and the benefits that are coming from our program, and then they would pick up some of the costs. They're not going to do that. They're not going to do that. They don't have the money, is what they say. So
Local government.
local government. Yeah.
But that is true. But we're in the same situation when it comes to mental health in our school system. You have 1 year left with the person that works in our school system, and then the bottom's going to fall out.
Yeah, you got the money. Yeah.
And she's funded through Great Smokies Health Foundation through the Replication Project,
Right.
Yeah, got her.
And we do have Heights in the school as well, but also their positions grant funded. And their caseload is unbelievable. Unbelievable.
Yeah, our care manager's the same.
I will say that grant with the UNC that's allowing for the telehealth in the schools. I mean, I don't know who has the information, but we really need to market that, because like I had no idea until like a few days ago that that was even a thing. And the mental health person for the school, she was like, "Yeah, we've got like 4 clients. We don't know why, we don't have any clients." It's like, because no one knows, you know. So I think it's important when there is something like that. That's wonderful. I mean, that's amazing. Let's make sure everyone knows about it.
So, reflecting back, we heard about a couple of good programs that are going on across the board, across the spectrum. But that's it, right? Like when we talk about transitional housing for people, we have Res Hope. And is that it? Nope. We got
They come through us, ICGH. You can come through Andrews and or Sea Level, and we can get. I mean, if they're willing to work a program of recovery, and we can get them engaged, and they want our service that they'll follow through, then we do have sober living opportunities. They can either go down to ICGH for behavioral health, for wellness, and then through there go into residential treatment for their transitional housing, their sober living. So
But it's to sorting to know that they're leaving home.
They're
And if we know anything about the people of Western North Carolina, we've got roots, and we don't want to leave if we don't have these.
trying to help.
Yeah, for sure. Yeah, and great. I mean, I wrote that down because it's such a great resource. But we need something here. I mean, we need something for our people, and not have to send them all the way to Wilmington or to Kannapolis or out of state.
And we did one time in Silva, we had a small nonprofit organization called Clean Slate that provided 6 beds for women that were coming out. And I was on the board for a while, and we had a wonderful like house donated to us. Like we had all kinds of things, but we were constantly hustling for grants, and we could not sustain that
So the funding was the issue there, not the program itself.
No, the program was
That's great.
Our beds were always full.
That's where I think that funding needs to be there for the nonprofits. Got to get people to jump in.
Because there are people in these communities who would do the work. Right there, the community wants it. Like you guys, like you would make it happen. But we can't without support.
Yeah, and I think you're not having to recruit at that point, right? Which then kind of speaks to all the issues, that we've heard today. You've got people embedded in the community already. And, I was even thinking about, your situation with housing, and how can we then promote from within so that we're not having to bring people from outside of our borders to address these needs. And I think like community health workers, peer support, that's kind of that foundation for that, right? They're already embedded in the community. We just don't necessarily have the funding or, the ability to then utilize them
For the work
Yes, that's right.
as well, so they can keep
Doing it. Probably would take some of the burden off of the clinicians, and it's harder to probably find, professionals if we could have those embedded in our community more and more readily available.
I mean, we have been very fortunate in our organization in that we participated in the HOP program.
Yep.
And in participating in that, we already have people in our organization that are trained. They're skilled. They know how to do case management. They know how to do all the stuff that needs to be done for people. We would have no need to have to hire people from without. They're people that are Graham County people. They live there. But again, it comes back to the funding. Where's that going to come from now?
Yeah.
So we.
And we still look at housing here. We looked at housing across the area to put housing here. I've talked to several, I call them politicians, about putting housing. I did receive pushback of, well, we don't want the houses in our community. Because I had identified multiple homes for us as a company to purchase. And the pushback I got was very heavy. It takes everything I can to be calm and collected. That's my job. And
You don't get paid enough. Whatever you get paid is.
I spend a lot of time with county commissioners throughout the state, and not too long ago I spoke in a rural area with commissioners. She was with me, and they were so receptive, and it was as rural as here. They were like, "We need you. We want you to come here and do everything that you can do in our communities." Up here, it's been more of maybe you can go somewhere else up here and put that.
That's the next time you
And then we and I can speak very freely about it. We also in Andrews itself come up here, identified property and wanted to put a facility-based crisis within Andrews, and not your fault, but
Well, it's not affordable.
right. I know.
Unless you have a gazillion dollar stash, it's a service that is like one of the most expensive services and is focused almost, unfortunately, a lot, at least 50% or more on people with no insurance. So there is no funding for it.
Right. And so for us, we were going to self-fund it, of course. And so we've had to look east because the MCOs out there are begging us to put our adolescent units in facility-based crisis.
Right. So you see, we're on the other end of that because we're moving into the housing
Yeah.
part and trying to determine which type of housing is going to best serve our community. And because we are not a government agency, we can do whatever we want to do with it, which sometimes is a benefit, because they have a lot of red tape and hoops and things that they have to deal with. And Graham County does not have the funds. They have lots and lots of things going on apart from all the other needs they have in the community. But those kind of conversations are conversations that need to be taking place with people that know the things that are happening outside of what the government may know it's happening.
Well, and the point all of our counties, they need affordable, just for everyone. Part of recruitment for our providers is, they can't find affordable housing for even the most, like a psychiatrist or their professional staff. So counties are focused on what they think is like affordable housing. But what we know is for many that we serve, that's not either affordable and it's not transitional. And substance use transitional housing is in this weird sphere because it can be, there's not a lot of funding that is like based on insurances. There's a lot of groups like religious groups or community groups that do transitional housing. And so it's sort of a odd thing. And that's just, like you said, not a focus. Many counties don't even have housing for the people, anyone in general, much less than trying to figure out how to do the transitional housing, which, you mentioned people don't want it there. I live in Canton on North Main Street, and there's actually a transitional housing like 3 houses down from me. I only know because my niece Samantha told me. Yeah, I would never have known. And they have like 5 homes across Haywood County. But you would never know it. Quiet, not a problem. People have such a misperception. It's like not in my backyard.
That's right. I lived in an Oxford house for 2.5 years after I got out of treatment.
Yep.
And we were the best neighbors.
Yep.
Well, we actually had discussed transitional housing and all about our opioid settlement funds, about that being a use we could do, and never could figure out how to make it work and make it be successful because of those things. But, in a perfect world, we would love to have a center in Graham County that allowed families to stay together in a perfect world. Because, that's what we need. We have so many troubles with families being torn apart already.
And a homeless shelter and a domestic violence shelter would also be rescue funds.
Then both of those would be great.
Well, we're over time. Thank y'all very much for contributing to this conversation. I think there's a lot more discussion to be had. So I will reach out to y'all and we'll keep this conversation going. I just wanted to wrap up by asking you a couple of questions, just kind of like all chime in. Do you think anybody should be able to receive mental health care around where they live? Yeah. Okay. Are they able to in this area? All right. Should anybody be able to get substance use care right where they live? All right. Yeah. Okay. Are they able to here? Okay. Should someone be able to get out of prison and come back home and make a life for themselves? Are they able to?
No.
Okay, great. We've got work to do.
Yep.
Thank you very much, y'all. Give yourselves a round of applause.